All right, so continuing on, I started up here because I put state kind of above medical director because I forgot to put state at the top. But who really oversees this is going to be at the state level. When we talk about the Department of Transportation, National Highway Traffic Safety Administration, all these people do is they dictate what has to be on an ambulance as far as equipment wise. That's kind of their role. Other than that, they kick everything down to the states as far as like what you're allowed to do. Your scope of practice is overseen at the state level. So coming from the state down, a medical director has to be a licensed physician. It does not have to be an ER doc. It can be an OD or a DO. It doesn't matter. Most of the time, these are ER doctors in your local area. Here in Routt County, our current doctor is Dr. Richter. He oversees, I think, all agencies in Routt County at this time. Coming down from that, you see protocols. Protocols are what you're allowed to do. It is usually pretty close to like your scope of practice, the standardized curriculum that you learn. In Colorado, we do have some additional things that we can do that's above and beyond your training. Like AEMT, you're going to learn about using fentanyl and Versed, which is not part of your education in the standard AEMT course. We're going to teach you that because you need it for Colorado though. But anyway, protocols here is you can look these up for Routt County. You can type in on the internet Routt County Protocol, EMS protocols, and it is a PDF, and the PDF changes automatically. It is essentially Denver Health Protocols is what it is. That's what we operate off of. So I encourage y'all, if you haven't looked at it, pull this up online, take a look at what it looks like. There's a table of contents, and you can click on whatever thing you want to look at, whether it be chest pain or it be difficulty breathing, and it'll drop you down to that place in the PDF and tell you what you need to know. It has all your medications on there and all the information about medications also. So good resource. From protocols, I come down over here to offline, sometimes called standing orders, or I come over here to online, sometimes called medical control. So your protocols are right here. If they're in your protocols, you can usually do it. You can perform the procedure, you can give the medication. If it's in your protocols, we kind of call that offline standing orders. It means I show up on an ambulance, I don't have to talk to anybody, I don't have to ask anybody anything, I can just do it. If we come over here to online medical control, this is sometimes in your protocols, it might say call physician before you do XYZ. Or if I'm like, I want to do something that's not in my protocols. I need to call medical control to see if that's okay with him. And you're like, who's medical control? Well, it's not the medical director necessarily. You call the receiving facility where you're going to take the patient to, and you get the attending physician on the phone, tell them what you got, what you want to do, why you want to do that, and see what they say. You can call cell phone, you can call radio, kind of depends on the doc, kind of depends on the place. All of your radio traffic is automatically recorded by the FCC, so some docs wanted you to do on radio for that purpose. But anyway, that's our difference. Online, offline, medical control, standing orders. Okay, coming on down, this is jumping around your book a little bit, but it all kind of falls under your medical director and your agency. But coming down here, QC, QCI, QA, sometimes people call quality assurance, is what this essentially is it is people that review your calls and see if we're doing what we should be doing. So in the state of Colorado, you have to do your patient care reports on a couple different platforms that the state oversees. So the state can pull up all of your patient care reports and they can take a look at what you gave, when you gave it, how the patient acted, your written narratives, all that stuff is documented, saved, it's recorded. And hopefully your medical director, your agency will go over all these, and whenever there's something that's like, well, Jeremy, how come you didn't give him oxygen at this point? And you can be like, well, this is why I didn't do it. They review, on the ski patrol, medical director reviews all CPR calls. He goes over and we do a little debriefing over any CPR calls on the mountain. Those are usually pretty big calls for us on the ski mountain. So anyway, this is just a way of reviewing stuff and helping us to become better, learning from our mistakes, finding ways that we can improve for the future. And these PCRs is a really good way to collect documentation. As far as, this is jumping ahead a little bit, but as far as like doing research, we used to did things because it sounded good, like putting people on a backboard. A backboard is a horrible immobilization device. It's a horrible spinal motion restriction device. It's a spatula, but we used it for years with no evidence. C-collars are kind of similar, but nowadays we're getting away from that. We're actually doing evidence-based research, so now it's scientific kind of what we're doing, which is nice. And a lot of this is because of our documentation. So the role we play in research is making sure that we document our stuff well. As far as coming on over, these are just kind of bullet points moving through the rest of your chapter. This stuff I just talked about with medical director protocols, offline standing orders, you're gonna see this on exams. You're gonna need to know what this is. This is all pretty fair game to see. Jumping on over here, talking about public access. In North America, we have pretty good public access to EMS. I've traveled a lot in Central South America, and yeah, we are definitely fortunate in the access we have to EMS. Even in the backcountry, we do pretty well with devices. But anyway, your book doesn't dive too deep into this. It talks about enhanced 911, which is kind of old school. It just means that like if they call 911, the 911 dispatcher gets your location, which is kind of like bare bones basic nowadays, I think. And then your book talks about EMD, emergency medical dispatch. Some dispatchers have a set of guidelines where if you call in with a chest pain or a cardiac arrest, the dispatcher will read you off instructions on what to do, and they'll talk to you before ambulance shows up, before firefighters show up. So that's kind of what this is. This world right here, public access communication, is just moving at lightning speed. So I would encourage you that maybe if you're working EMS somewhere, take a trip down to the 911 dispatch area, talk to them about what they do, how they do things. I had a student take my class that worked for 911, and she was kind of telling me the things they do in Routt County, and I was kind of blown away, which I really can't remember, but I remember it was way far advanced than I expected to hear. But what you all need to know is what is enhanced 911 for a test. Coming down here to mobily integrated healthcare, also known as community paramedicine. This kind of came about from the Affordable Health Care Act, and this was in an effort to kind of do what we used to do back here in 1861, which was to take our medical providers to the homes. Instead of bringing the people to the hospital, we bring the medical care providers to the house. So this is like, after you've been a paramedic for a little while, hopefully, you go get some more education that gets into community paramedicine, and you learn a little bit more, and you go to people's homes and treat them and take care of them there, and don't bring them to the hospital. Lots of different systems going on across the country right now. This is actually a bachelor's degree in some places, but we're still kind of figuring out this world and how this works, how the billing works, the scope of practice. All this has kind of been developed. Some community paramedicine we've been doing in rural areas for a long time. Taught up at Walden for a while, and like that guy up there, it's like he knows everybody in town. His wife knows everybody in town. They're both medics. They do checkups all the time, going to people's homes, checking on their medication, helping to refill stuff, seeing how they're doing. But that's kind of what community paramedicine is going to check on people that you know sick. We used to do this in Georgetown, Kentucky too. We had a list of people that would check in on once a week just to see how they're doing. So anyway, community paramedicine. We talk about EMS financing, like how are we funded? We need to get paid, so it's important for us. And the answer to this is it varies from place to place. A lot of agencies are paid for by tax dollars, whether it be a mill levy. Sometimes like in Knoxville, it was a for-profit private agency, and the city contracted out this EMS service to provide 911. Sometimes it's through grants, or at least assisted with grants. So a lot of different ways EMS kind of gets their financing. There's also volunteers too. I threw these up here. There's no way I'm going to remember what these stand for, but these are two bodies, kind of nationwide bodies, that assist with our credentialing. At the EMT level, you don't have to be credentialed by either one of these, but as an AEMT, you do. So I just threw these up here so you at least see them once. I don't know what they stand for, so obviously it's probably not too important for you all. Coming down to prevention and public education. This portion here is like, there's not a whole lot you're gonna need to know for a test around here, but I encourage you all to be part of the public, be part of the community you work in. You want people to know who you are, and educating people is how we help to save lives. And yeah, hopefully save lives. Some stuff, examples of this be like educating people about seatbelts, educating people about helmets, stuff like that is how like prevention is. Firefighters did a really great job of prevention as far as teaching people about fires in the house, how to prevent fires, and then yeah, like they almost worked themselves out of a job. I don't think we're working ourselves out of a job. The automobile industry did a really good job on reducing injuries in the way they build cars. And also like public education that's really big now is like teaching people about drugs and alcohol. So anyway, I encourage y'all to be a part of this. You all are now a part of the community and helping the community at large. You're a public servant. So do what you can to help people out. Leapfrogging that down into human trafficking. This is on page 23. You're gonna be in places that other people don't come to. So when you see something that smells bad, looks bad, doesn't look good, it's probably not. So looking back on calls, I would guarantee that I've been on some calls where people were being trafficked. It didn't come to mind to me back in the time, but on page 23, it has a number for you to call. If you suspect anything, you should report it. There is a lot of human trafficking, not just sex trafficking, but there's also trafficking for labor and a bunch of other stuff. Our role in EMS research we talked about just a little bit ago, so we're not going to go over that. As far as specialty clinics, what that means is we have hospitals that are dedicated towards particular types of injuries, whether that be burns. So we have a burn clinic, a burn hospital down on the Front Range, children's hospital just for pediatrics. We have psych wards for people with behavioral problems. We have women clinics, we have OB clinics. So there are some places that just specialize in one particular type of care. As far as interfacility transports, we do a lot of these in EMS. It's a pretty big moneymaker. So you're going to, in this EMS agenda for 2050 is putting emphasis on getting people to the place they need to be to get care taken, to get good care taken of them. So probably seeing more and more of interfacility transports. A lot of these smaller hospitals, especially like Steamboat, Craig, you know, like in Walden, it's like that's not a good place for them to be. It's not where they're getting the best care. So take them to where they're at. It might be because their family's in another place also. So take them to a hospital where their family is around. They can have better care from home. And this, working with hospital staff, this also falls in this new agenda. So they were really trying to encourage us to get to know the hospital a little bit better, get to know the people better, have a better working relationship, know what the hospital expects. When I started paramedic school, I remember I was a huge advocate of like Denver Health because it was a hospital-based ambulance, and to me it made sense. Like you show up on scene, and I'm taking care of this patient. I go to the hospital. If I work for the hospital, I'm going to be in the hospital taking care of the patient. I'm going to know the nurses. I'm going to know the techs. I'm going to know the doctors. They're going to know me. They're going to give me feedback, and it's like you're kind of one big team. This made sense to me back in the day. It was like 20 years ago. And you know, if you work at a independent service like in Knoxville, I worked as a for-profit independent. Like I didn't know any of the hospital people. I didn't know any of the doctors. They didn't know me. I never got feedback from any of my calls there. So working with the hospital staff, I encourage your local area to get to know those folks. Go in, hang out with them, bring some food in the hospital, bring some treats to them. If you're hanging out there, maybe help them out, make a bed, clean up someplace. But yeah, you're all one big team is what I'm trying to say with this. And then work on public safety. It's kind of like the hospital is in building, public safety is out building. So get to know the cops, get to know the firefighters, get to know search and rescue, working on the ambulance in Craig. It's like the cops are some of my favorite people there because we definitely go on a lot of calls where I don't want to be alone. We go in some pretty sketchy places. So getting to know whoever works with you, maybe air medical or something like that also. And come down here for roles and responsibilities, you all. This seems, whenever I was younger, I kind of looked at this as like, sure, whatever. But roles and responsibilities kind of starts with like how you dress, how you show up to work. And that starts the night before. So getting a good night's rest, drinking enough water, getting enough exercise, taking care of yourself. And then when you show up to work, like you should look nice. Say that with my shaggy beard on right now. Yeah, so I mean, come to work with like your boots are well cleaned, your pants are well cleaned, your shirts are tucked in, your beard or whatever is trimmed. Like when those people see you for the first time, they've already made a judgment of you. So you can start yourself off on the right foot by walking in and just looking professional. And roles and responsibility going along is like you're always a patient advocate. That's what we're there for. I tell my students, and I'm going to tell you all this, like most of the calls you go on, these patients aren't dying, they're not critical. It's very rare when we actually like get it to like really work, which is what we love to do. But most of these people just want to have someone pay attention to them. So get them in the back of the ambulance. Sometimes the best thing they've got in that month or that week or even that year is to have you sit there and ask them questions and actually listen. Give them a warm blanket, give them a pillow, make their day a little bit better. So that's your role and responsibility, is always being a patient advocate. I could dive deep into this if I wanted to. If y'all want to look up a guy who spent his whole life doing this, his name is Dr. Goldfrank out of